Thank you, everyone, for joining us. I'm Dr. Davidicus Wong, and so appreciative that you can join me on this freezing cold, snowy day. So I hope everyone had a nice, safe day, no slips or falls or car accidents. And be careful, check the weather before you step out the door tomorrow. I came back from work early just to do calls from home because we didn't want patients coming out to the office at this risky time with the snowstorm. And I was able to make it back in time, of course, for this important talk. So I'd like to share some key points that will help you or a loved one get the most of your next hospital stay. And it's going to be kind of like a traveler brochure and key tips because the hospital is a strange land. I kind of grew up in it, so I can give you some advice as a previous inhabitant as well as a staff member at the hospital, and then as a family doctor. So the name of this talk is The Lonely Patient's Guide to Hospital Land, Making the Most of Your Hospital Stay, brought to you by the Burnaby Division of Family Practice. And I'd like to introduce you to my partner in the Empowering Patients program, our public education program, which is now 10 years old. And I've been working with Leona from the start, and she does a lot of the behind the scenes activities, but she does a lot of activity as a manager through the Burnaby Division of Family Practice. So I'll turn things over to Leona to kind of update you on some resources that are available to everyone in our community.
Good evening, everybody. Thank you so much for joining us tonight, and Happy New Year. I never know if it's too late to say Happy New Year, but I do wish you a Happy New Year. So I'm just going to share as some of you who are returning viewers, some resources that are available through the Burnaby Division. The first one being, this will be all in the chat. The first one being our Empowering Patients program page. That's our general page that has the schedule of upcoming events. We have one more talk of the season, and recordings of all of these talks. So this talk is being recorded, and tomorrow I will post that link up on the website, and you can view it at any time or share it with friends, family. So please be sure to do that. That's what it's there for. The other link is going to be for Empowering Patients resources. So Dr. Wong puts these presentations together for us, and he also puts together key points documents. So there's the second link I'm going to share is the links to all of those things for all of our talks. The third link will be our Looking for a Family Doctor page. So some of you who don't yet have a family doctor and are Burnaby residents, I'm going to post a link to our program, the Patient Attachment Program. Unfortunately, there is a substantial wait for a family doctor, but it's important to get yourself on the list. So please do so, and feel free to reach out to our team if you have any questions. The next link will be our Primary Care Networks link. That's PCN. In Burnaby, we have a very active PCN, and that's our partnership with the Fraser Health Authority, the City of Burnaby, and some community partners. We've been able to establish many resources for our families to refer you to if you have a Burnaby family doctor. So lots of information there. It's a good read, informative read. And then under the PCN umbrella, we also do online health talks called Doc Talks, and there's several other topics by other Burnaby doctors. And so those are, if you're looking for something to do on a snowy night, check out some of those talks. The next one is link will be to our monthly health and wellness newsletter that we put together. We vet resources. We'll give you updates on all primary care networks or PCN new news. So I'll post a link to that, and that's a subscription newsletter. If you're interested in receiving vetted information, you can just take a look at our January issue and subscribe at the bottom, and then you'll receive our February issue, which will come out either the first or second week in January, and it comes out on a Friday. And the last link I'm going to share for you is a link to register for our last talk of this season. It's on February 29th, and the topic is Making Sense of Symptoms and Screening Tests. Dr. Wong's put a lot of information together for that, including a chart that you can print off, again, share with your friends and family, put it on your fridge, just to keep track of those, all those things that get lost in our brains. And we're possibly going to host that one in person. So stay tuned for more information on that. And that's all I've got. Back to you, Dr. Wong.
Thank you, Leona. Thanks for all those updates and all the work you're doing behind the scenes for everyone in our community.
My
So this is
pleasure.
a pic. Oh, thank you. So this is a picture of Burnaby Hospital. So it's the hospital that I spent some time in when I was 10 years old, like grade 6. I had rheumatoid arthritis as a kid, and I had a bad flare-up in grade 6 and was stayed in this hospital, one of those floors with windows, when I was a kid. And it was there, which is a scary experience, that I was really comforted by the doctors, nurses, and the other healthcare providers that treated the patient, treated me as a kid, not treating a disease. And I had confidence in them, and I was impressed by their knowledge and their skill, but mainly their compassion. And I realized this is what I would like to do, that I would like to be a healthcare provider and have enough knowledge and skill so that I can provide professional support, but also compassionate care to any individual that's in distress and needs our help. So I'm living the dream. But Burnaby Hospital stayed looking exactly the same since I was in the hospital until I went on staff in 1992, all the way up until now, where they're actually building a new Burnaby Hospital. So this old building still stands, but it's getting a big expansion, long awaited. But the atmosphere, the culture of hospitals is unique, and that's why I wanted to have this kind of guidebook for all of the lay people that aren't familiar with the hospital language and the customs. And most importantly, some key things that you can do, or if your loved one is there, that you can do as your loved one's advocate in the hospital to make sure that the wishes of the patient are understood, that you get the information you need, and that information flows back to your family doctor if you're lucky enough to have one. Again, brought to you by the Burnaby Division, which is a nonprofit society that whose members are the family physicians and nurse practitioners that serve the Burnaby community. So I was really fortunate to be part of the division at the start, one of the founding um, board members, and for a time the chair and the medical lead, and member of the board for a number of years, and still lead with Leona the Empowering Patients program. That's our outreach to the community to share public health information that you may not normally get from unbiased sources. You get lots of health information from a variety of people that are trying to sell you something or are advertising. But we wanted something that was unbiased, where no one's trying to sell you anything but your own well-being. So that's the main reason why we're here, because as family docs, as all healthcare providers, we care about our individual patients, but we also care about our community at large. And together, all of you are a part of the community and caring for the future. Not only our children, but the elders, newcomers to our community. We're all important to support one another. So as family docs, we care about our patients, and we're out there and we care about our community. We like to talk the walk as well and walk the talk. So I'll be talking about just a review of the 4 foundations of looking after ourselves, which is kind of the main theme of our Empowering Patients talks. And the topics in the previous presentations, including videos and the key point handouts for all the recent talks in the last 2 years, are available on that Burnaby Division website under Empowering Patients. And then I'll give you a tour of hospital land, a strange land with strange customs that all of us sooner or later will have to visit. I'll talk about risks and dangers to watch out for and how to prepare for your visit, what to pack, and 3 ways to have a better stay. Yeah, just an overview, what is healthcare? It's not all the things that healthcare providers do, and it's not just the acute care in the hospital. Most of your care occurs in the community. And the person that provides most of your healthcare is not me, your family doctor, it's actually you. We're here to support you. So we need to connect you with the resources you need. We need to listen to you. We need to help you achieve your goals and to be proactive and let you know what recommendations we have for better living, better health. So healthcare is really self-care, and we're here to support you. The best predictor of your future health of those things that are under our control are the habits we practice every day. So an ongoing theme is the 4 foundations of self-care, including what you eat, like a healthy diet, what you do, physical activity, including exercise, how you feel, emotional well-being, and very importantly, how you relate, your relationships. So what you eat comprises what you put into your body, healthy food as well as unhealthy food, and also other things that we put into our bodies, including alcohol or nicotine or other drugs. So this is a major talk. We do have a video that's available on our website. And then in terms of what you do, physical activity balanced by appropriate rest and sleep. In emotional well-being, managing stress, managing our emotions, and finding meaning in our lives. And then finally, how we relate, healthy relationships. So we've done a recent talk on healthy relationships and the keys to resolving difficulties and the keys to fostering healthy communication. So if you need any refreshers, like we all do, take a look at our website and you can download some of the videos or watch some of the videos again on slow nights when there's nothing left on Disney Plus or Netflix. So what do we need for good self-care? Complete health information that's unbiased so we can adopt healthier lifestyles, manage our health conditions, including chronic conditions such as diabetes and high blood pressure, also topics of my recent talks. And we have an upcoming talk on making sense of symptoms and screening tests. So that'll be an overview because a lot of people no longer have regular physicals because that's not a medical services plan benefit. Some people with chronic conditions, systemic conditions do need a head-to-toe physical. So most people are not asked the questions that we are traditionally taught as medical students, the review of systems, so that we identify symptoms that might indicate disease that require follow-up. So this presentation will kind of go over the symptoms to watch out for different body systems, such as the respiratory systems. But you should see a doctor if you're coughing blood or you're feeling more shortness of breath, or you have a chronic cough that's obviously not COVID or RSV or influenza. Or in terms of the endocrine system, the hormone system, if you have urinating large amounts, large volumes, drinking lots of water, having a huge weight gain or weight loss, could be indications of a metabolic problem such as diabetes. So how to identify worrisome symptoms and when to see a physician or other healthcare provider, but also what are the screening tests that we need at different ages depending on our gender. And we've had talks on improving patient-doctor communication. So I'd like to refer you to that, and I believe we'll be including that as one of the key point handouts today. Kind of those key things that you should discuss with a healthcare provider before you agree to a particular test, including lab tests or surgery or medications, the key things that you should know. So I'll touch on it as well because that has relevance during our hospital stays as well. So I'm no stranger to the hospital. So I went on staff at Burnaby Hospital soon after graduating and doing my rotating internship in Victoria. I graduated from UBC, so I didn't wander far from home. And then I came back to practice in my own hometown of Burnaby. And one of my first positions was on the Ethical Resources Committee just a year or so after I came onto staff, because I had a special interest in medical ethics. You know, the role of patient's voice, autonomy, the role of confidentiality, and informed consent, giving the patient the information he or she needs to make an informed decision, and how to make decisions about whether a patient is still capable of making their decisions, and who to turn to in their family or circle of friends to make decisions on their behalf. So I was involved in that committee from a long time, from 92 to 2007. So a number of years, a decade and a half. And in the last 10 years, I did the ethical consultations with key members of our Ethical Resources Committee. And we've all become good friends and trusted in dealing with the most difficult cases. They would consult with us if a patient was, for example, in the ICU or CCU, not improving, on life support, and they were having difficulty agreeing between doctors, nurses, and family whether or not life support should be continued or should it be stopped, and who has the right to make decisions. So those are really difficult ones, but we always found consensus and resolution with families when we looked at what values the individual had, searching out for indications of some advanced medical directives. So what we learned and what we tried to teach throughout the hospital, the staff as well as the public, is that it's best to consider what interventions you want in hospital before you come to the hospital, to have that discussion ahead of time. And that's one of the key points that we'll be discussing this evening as well. Between 2003 and 2008, I was head of the Department of Family Practice. So there used to be a huge number of family doctors at Burnaby Hospital. So when I graduated and wanted to go into family practice, my brother, an anesthetist, who was familiar with all the Lower Mainland hospitals, said, the hospital you want to go to be a family doctor would be Burnaby. Because Burnaby, the doctors, the family docs are actively involved in throughout the whole hospital. They're the heads of numerous departments besides family practice. In fact, family docs were involved in 2 departments at one time. We would choose between family practice and obstetrics if we do deliveries, or family practice and pediatrics, or family practice and internal medicine. And then often the family docs would be the heads of those departments as well, alternating with the specialists. And in those days, when we were on staff at Burnaby Hospital, those 200 or some odd doctors at that time, we would take turns being doctor of the day. So that wasn't like employee of the month. It means if any patients come into Burnaby that don't have a family doctor in Burnaby, we would be their family doctor for that stay and kind of be the most responsible physician and work with a specialist and see those patients every day, or for supportive care to guide them through their hospital stay and then connect them to the community after. So I met a number of my future family practice patients in that way. But then after a time, after many years, I believe it was around the 2000s, the Health Authority introduced hospitalists. So it was a pilot project for the first hospitalists in Fraser Health. And they would be family physicians who no longer had practices outside of the hospital, who would just look after the patients that didn't have a family doctor. So they kind of worked side by side with family docs that were still seeing their patients. But because those hospitalists were being paid much more than what we were being paid to look after patients in the hospital, a huge number of docs, over 100, maybe 150, quit en masse. They gave up their hospital privileges. And year by year after that, more family physicians put in their resignation for practice. And that's why today, it is rare in an urban hospital for a family doctor still to be looking after their patients. It would be the hospitalists and specialists working together to look after your stay when you go to the hospital. So it's quite different from what it was like before. So we'd be up late at night with our patients with congestive heart failure or a hypertensive emergency. We would take turns on call. So I believe I was one of the last 2 physicians still seeing their patients. The other was Dr. James He, who's now retired. And then we would see our own patients, no longer had a big call group of other family docs. We worked the hospitalists so that if I had to be away for a weekend, they kindly agreed to look after my patients. But it became harder and harder being on call every day for our patients when we were in town to just, be able to maintain that. So eventually I gave up my daily admitting privileges for admitting my own patients to hospital, as I was one of the last 2 doctors to do so, but continued doing deliveries for my patients, which I finally stopped doing last year because, again, family doctors gave up obstetrics, and most family docs that are doing deliveries are part of an obstetric maternity group that work and take shifts within the hospital. So it was lots of fun, but I am getting much more sleep now. But I really miss that team approach with working with the nurses and the hospital staff and caring for our patients. So when I was the head of family practice, eventually I became the head of the medical advisory committee, which is all the heads of all the departments, all the specialty departments all together. We would make medical decisions, and then one of us, the head of the local medical advisory committee at Burnaby, would go to the monthly health authority medical advisory committee. So for the first few years as the local medical advisor, chair, I would go to the Health Authority Medical Advisory Committee in Surrey. And eventually I became the chair of the Health Authority Medical Advisory Committee, and I served for 3 years. And that was kind of my limit of administrative work because it was quite overwhelming in addition to looking after my own patients, which is the core of why I'm in family practice. So let's start our little guidebook, Making the Most of Your Hospital Stay. So this title is inspired by the Lonely Planet guides that people use for the insiders look at the culture and the customs and getting by when you're traveling in Thailand, Brazil, Australia. But this is a special one for when you land in the hospital land. So a hospital is like a foreign country. So you'll see their inhabitants, and maybe because they're foreign to you, they all kind of look the same. So we all dress in these scrubs. So these scrubs or greens, or in my case, blues, they're kind of like the uniform that kind of look like pajamas that pretty well all the hospital staff wear. So if someone's wearing scrubs or a lab coat, a name tag, and a stethoscope, they could be doctors, they could be nurses, they could be respiratory technicians, they could be speech therapists. Subtract the stethoscope, they could be also the cleaning staff. So when we had our educational rounds at the hospital, they'd always be one of the Senate the janitorial staff that would come have muffins, coffee, and he probably was the most informed non-medical staff in the hospital, having sat in all the grand rounds. I'm sure he wasn't there just for the coffee and muffins. So I'll give a tip on how to identify different people in the hospital, but the key is the name tag. But don't be shy in asking if you're not sure if this person in scrubs or white coat is a doctor, a nurse, a respiratory tech, or a janitorial staff. So one of the key is our name tags, and they usually tell you if we're a physician, might have a specialty. It's how we get into the hospital and get past security ourselves. Also, these inhabitants, the hospital staff, speak a different language. We kind of speak in code. So you'll probably hear things announced overhead, like code blue, which is a medical emergency, sometimes a respiratory or cardiac arrest, or sometimes someone that's acutely short of breath. So there's a team that will go up to that ward. So you might hear code blue, emergency department, and then a team will go there to resuscitate an individual. Code white is, you're right, it probably involves white coats, but that could be a potentially violent patient on a ward. A code red is obviously a fire. Code pink is usually emergency in maternity or the newborn areas. A code yellow is not necessarily someone urinating. A code brown is not someone pooping on the floor, but it's usually another toxic substance. When you're in a place like Hawaii, one of my favorite places, because it's in that place where people only expect me to speak English and treat me like I'm born there, kind of like how Vancouver should be, but I feel at home in Hawaii. So in Hawaii, aloha means hello, goodbye, I love you, welcome. In the hospital, we have words that mean many things too. So you might hear the doctor doing rounds, but that can mean many things. So doctor's rounds are usually when the physician is going around seeing his or her patients on the ward. Grand rounds is when we're actually having a talk or a presentation. Team rounds is where a team on the ward, so doctors, nurses, social workers, speech therapists, all of the allied health staff that are involved in the care of the patient on the ward will go around and talk about the new things for this individual patient and what needs they have and what the plan is for them. And brown rounds is actually not a real name for rounds, but it's when we used to go to radiology to speak to the radiologist to talk about an x-ray, and the radiologist is on a coffee break. And the hospital staff, these inhabitants do have some strange customs. You'll notice that when you get admitted to the hospital, we slap on a wristband, almost like you're at an all-inclusive resort because they're really hard to take off without scissors. So there are some bands that you have that just show your allergies. They might be a bright color like red to indicate that. But most patients have a wristband that's going to have their PHN, their name, their birth date. So just to make sure when someone's taking blood or wheeling someone off for an investigation or surgery, that that patient is identified. In fact, when the wristband goes on, they usually verify with you that that's your name, this is your birth date, that we don't have any confusion. There's lots of double checks and triple checks to avoid errors in that way in the hospital. But also on that band is usually listed the admitting physician. And usually, at least at the beginning of your hospital stay, that's the most responsible physician for your care. And that should be the physician that you're familiar with in discussing your care with. Also, people dress differently. We talked about the scrubs that we wear as hospital staff, and we all look about the same. So look at our name tags and don't be afraid to ask what our role is in your care. But of course, we often put patients into hospital pajamas or hospital gowns. And it can be quite depersonalizing. So I had to wear one of these things when I was a kid, and it was kind of strange wearing not my own clothes anymore and pretty skimpy clothes as well, that sometimes cover some parts of your body better than others. At Burnaby, we have better coverage, and we make sure you don't go out and look indecent to other people. And the really unnerving thing in the hospital is that traditionally there's this big binder that has everyone's name on it on the ward. And in that book, someone is each of the healthcare providers and all the healthcare team reads the notes, writes notes on you, orders by the doctor are written in this binder as well. It has lots of tabs and tags to separate investigations, lab work, consultations, and medical orders as well. There's areas for nursing notes, areas for doctors' notes, and areas for allied healthcare providers' notes. These are gradually being replaced by the virtual chart, like at your family doctor's office. So instead of charts you see on the walls, they're actually in a computer with various levels of security to make them much more secure than even your bank records. But it is a bit unnerving. So if I was a little bit older, if I had an infection and fever, I was a little bit delirious or confused, I would get a bit paranoid about people talking about me outside my room, writing in a book that has my name on it, that's all about me. But me not knowing what's actually inside that binder, what they're talking about. And they're also speaking a strange language that sounds a little bit like English, but with a lot of complicated Latin and Greek words thrown in just to confuse me. So I don't blame patients in that situation for being a little bit paranoid, confused, and very anxious as well. And of course, we have a variety of cuisine. In some countries, I've learned when we go to Mexico that a 5-star resort is really only 3 stars. But I don't think you'll even get 3 stars in the hospital, but we do have dietitians that make sure that it's a nutritionally appropriate diet for the individual. And we have speech language therapists to make sure it's the consistency that's aligned with their ability to swallow. So a general rule that doctors have is when the patient stops throwing up and they start complaining about the food and it's only 2 stars, the doctor starts to think that you're nearly normal and ready for discharge. So a really important, serious thing is informed consent. So as a patient, in or out of hospital, as a healthcare provider, I need to provide you enough information about the benefits, risks, and alternatives of any test or any procedure, including operations, or any medication before you can choose or decide to refuse it. And some people don't realize because of being put in different clothes, being made to follow the schedule of the hospital, we lose our sense of autonomy, and it's easy just to kind of fall back on things and not to question things and ask for clarification. So one important thing to retain your autonomy or sense of independence is to make sure that we're providing you with the information you need to make the informed decision. So informed consent is one of the key things in medical ethics that I try to reinforce over my years with medical ethics, educating hospital staff as well as the public. So the two key things you need for informed consent are, one, enough information, and also the individual patient has to be capable of understanding that information and making an informed decision. So in the hospital, there are translators if you're not an English speaker or comfortable with your use of English. So we have a variety of different languages, and so that should be available for all patients. But there are other things that can affect our ability to understand, including illness that can cause confusion or even loss of consciousness, like with a stroke or coma. So when a patient is not able to make their wishes known, then we have to rely on a substitute decision maker. Usually that will be the next of kin. And then it goes down from spouse to adult child, or if there is none available, then it might be their best friend. But it's always better if you think you may be in a situation where you're in the hospital and they need to speak to someone to make your voice heard, to plan that in advance with your loved ones or your best friends, so that, and maybe even formalize that with your family doctor or put it in the document that we'll talk about later. So sometimes, as I mentioned, due to illness or incapacity, you may not be able to give informed consent. So who's going to decide on your behalf? So of course, there are dangers in every foreign country. And of course, the dangers in hospital are infections like hospital-acquired pneumonia, methicillin-resistant Staph aureus, or MRSA, or C. difficile diarrhea, or picking up COVID for another patient in the next bed. So there's always these risks for infections, and we're always on top of things and monitoring the numbers of cases so that we can take steps to prevent risk to individual patients. There are also complications of procedures. So every drug, every treatment, every investigation has its goals and its benefits that we're trying to seek, but also has its risks, either big or small. For example, the catheters that we have to put in the bladder, someone cannot urinate, that could be in itself be a cause for infections. We can get infections or bleeding with any surgery. Usually that's a very low risk with the skill of our surgeons and our surgical staff and the post-operative staff as well. We can be at risk for aspirating if we have difficulty swallowing, like after a stroke or with other medical conditions. So that's where food comes up from the stomach, and those bacteria from the stomach infects the lung. And of course, if we're immobilized and lying in a bed for long periods of time, we develop sores for just the skin rubbing on the same areas in a chair or on the bed. And those can become infected and hard to treat if we're not very mobile. So nursing staff is always on the ball looking out for these risks. And of course, medications, as any other intervention, has its potential side effects that we should inform you of in advance and to be on the lookout in case they arise. And when you involve many different people looking after your care, there is that risk of human error, as we all are human. There could be miscommunication. So the hospital and the health authority have taken special steps to reduce this miscommunication. Like doctors' handwriting and writing doctors' orders could be a big source of miscommunication. And there's certain abbreviations that could be confused quite a bit too. So we've taken steps. In fact, as hospital staff, I've had year after year, we have to kind of go through this module that reminds us of what are acceptable orders to write, how to reduce miscommunication. And those policies have had a great effect in reducing some of these chances of human error in your orders. And nurses are always double checking to ensure that the correct dose of a medication is given and the right drug is given as well, and that we're giving it to the right patient. There's lots of double checks and triple checks to make sure we have the right individual. So these risks, these errors are rare because of the safety culture we're adopted. So if any patient has a mishap or a near miss, we have the culture in our hospitals and the health authority of making sure it's reported, that all patient complaints and family complaints are reported, and we take steps to see what the cause of that error was without pointing to a particular person for blame, because we want to help the system so that all the risk, it's called the Swiss cheese model. If a lot of things are not attended to in the process, it leads to complications. But if we take steps at every possible route where we can have errors, then we can greatly reduce the risk to the individual patient. So what should you do to prepare for your visit, knowing that you might end up in the hospital anytime through an accident or a medical emergency, such as a stroke or heart attack or a broken bone or an infection? So I keep hearing this bad advice that people say that their mothers gave them, to always wear clean underwear in case you get into an accident. But when you think about it, if you do get into an accident and you get really surprised, you're more likely to poop and pee in your clean underwear anyway, right? So my advice to you would be never miss an opportunity to go to the washroom, and don't wear old underwear that you'd be embarrassed to be seen in, whether it's clean or dirty. So don't wear your best underwear, as we often will end up cutting them open if it's an emergency and we have to get to those body parts in an emergency. So maybe not wear your Superman Under Armour undershirt or your Calvin Kleins if you are planning to go to the hospital, because again, in an emergency, cut them off. What should you pack if you know you're going to the hospital? Well, you don't want to pack your most valuable prized things, but there's some key things. So when you travel to a foreign country, you obviously have to bring your passport and some crucial medical information. So the key things that you should bring, I think every patient, at least an adult patient, or anyone with some medical history, should carry a one-pager. And if you don't have one, your family doctor's office can help you provide you one, because we all keep a summary of your chronic medical conditions and your current medications and any important surgery you've had in the past. That's kind of a college requirement for our office record. So if you have a one-pager with this crucial information, it would help so much if you ended up in the hospital, an emergency, or even an urgent care walk-in clinic, because it's just one page that shows if you have allergies to medications or anything relevant to a hospital stay. So food allergies are relevant too, or allergies to adhesives or to iodine. Your medical history, the one pager should have your chronic medical conditions, such as high blood pressure or asthma or chronic lung disease. You should have one of your health habits. If you smoke or if you're drinking more than 3 drinks a week, you should include that in your medical history. And significant past illnesses and operations that you've had, roughly the date or the age you had it, and preferably the medical name for that procedure. So if you're not sure the medical name for when you got the gallbladder taken out, which is a cholecystectomy, you can ask your family doctor for the medical term, because too often we sometimes simplify things for patients and kind of give a general common name for a procedure, but the actual name of the procedure is really useful for other healthcare providers to know. And also importantly, your family medical history. If there's a history of particular types of cancer, like colon cancer, or a history of a heart attack or stroke at a young age, like in our 50s or 40s rather than our 80s and 90s. So your allergies, chronic conditions, past illnesses and surgery, your family medical history, and of course, your medications. If you're taking any medication, whether it's 1 or 10, these are the key things you should know about every medication. One is the name. So there's the brand name, like Viagra, and there's the generic name or the molecule, which is sildenafil. You should also know the dose, whether it's 100 milligrams or 50 milligrams. So just saying 1 pill or 1 mil isn't really enough information. We need kind of the milligram dose usually. And the directions, whether it's taken by mouth, whether it's twice a day or 3 times a day, or taken just at bedtime. And the fourth thing to know and to note on your record is the indication. What is the condition we're treating with this medication? Sometimes it's obvious. For example, Ramipril or Alteis, a blood pressure pill, is used commonly for blood pressure, for high blood pressure, but it's also used for congestive heart failure. They help the heart pump a bit stronger. And it's also prescribed if someone has some kidney problems that require that to control the blood pressure as well. So knowing the medical reason for the drug is useful more than just the drug name itself. So these 4 key things to know about every medication to record on your medical record. Another example, Tylenol. The brand name is kind of like your given name, in my case, David. Generic name is kind of like the last name, so that's the molecule name. You might look at your prescription and just remember the first 3 letters. That actually doesn't help too much. Often on your prescription, if it's a generic drug, it may have something like APO, APO, or Mint, MINT. That doesn't refer to the flavor. That's just the generic drug manufacturer. So if you only remember that prefix, it doesn't tell us what the drug is. So write down the entire name and also a molecule name or generic name. So there'll be 2 names on your prescription label. If you're not sure, ask your pharmacist or show it to your doctor, and they can just clarify so that you know the full name of the drug. The dose, again, is usually in milligram size, and the directions. Example, 1 tablet twice a day. And the indication for this patient would be for knee pain or osteoarthritis. And that other example, Ramipril, can be used for high blood pressure, but it can also be used for heart failure or other conditions as well. Another crucial bit of information, an important document would be your preferences. What would you want done in your healthcare? What would you not want to have done? So best to decide ahead of time. Because every patient that comes to the hospital, that question is asked when you're admitted, regardless of age. So if you have certain religious beliefs that preclude or would forbid certain procedures, for example, members of the Watchtower organization, it is against their religious beliefs to have blood transfusion. So that's really important to note, especially if you're unconscious and in for an emergency and have lost a lot of blood. They need to know that they need to use other means, not a transfusion, to treat your medical emergency. And the other important thing is advanced medical directives. So a directive or instruction from you in advance of something happening so that we know what you want when you're capable and competent of deciding. So formally, an advance directive is a statement of your preferences for the types of medical care and is to be referred to when you're unable to make your own decisions. So what procedures would you want done? Would you have surgery? Would you have a tube placed into your trachea if you couldn't breathe on your own? For example, after a severe stroke and you're unable to breathe on your own, or if you've had a heart attack and you're not breathing and you need assistance for respirations. So what do you want and what would you refuse to have and under what conditions? So a lot of people, it's pretty easy to say, if I'm going to be a vegetable and have no brain function, I don't want to be kept alive on a machine. So that's an obvious one for pretty well all of us. But at different ages, different conditions, we might make different decisions. For example, if I were to have a sudden cardiac arrest, like an electrocution, my heart stopped, I would want to be resuscitated because for a healthy younger person in good health, there's a good likelihood that if we caught you quickly right after a cardiac arrest or serious arrhythmia, we can treat it and a good chance you'll survive. However, the older we get or the more chronic conditions we have, the less likely it's going to be successful. In fact, a general statistic is for the average adult that has cardiopulmonary respiration like chest compressions or assisted respirations if they're not breathing or their heart stops. About 15% or 3 out of 20 actually survive, get revived from CPR, so a pretty low number. And only 1 out of 20, like 5%, will likely survive from being resuscitated and being in the hospital to actually getting out of the hospital and being able to return home. So many of them will be in the hospital for a long time or end up in a long-term care facility and not regaining their functional abilities. So we need to know what makes your life worth living at every stage of your life, and what things would you not tolerate or not want done to you. So these are complicated discussions, and it's best to discuss your wishes with a healthcare provider so we can answer any of your questions, and with your family so that they will respect your wishes as well. So often with the ethics consultations that I did over the years at Burnaby Hospital, there would be family members that disagree. So one family member um, felt they wanted their parent to be kept alive, even though the parent had indicated in the past they would not want to be on life support machines, that they were not likely to regain consciousness and be able to have an active, worthwhile life from that patient's perspective. And then another child, substitute decision maker, would want to respect that parent's wishes. So one would want them to stay on life support, one wouldn't. So often we would have to take a step back and determine what the individual patient had expressed and what they wanted in their values. So as I mentioned, you may not wish to have CPR, chest compressions, assisted breathing, or a tube put on, or electric shocks or defibrillation. If you had an irreversible condition from which you would have no hope of returning to an acceptable quality of life. And the acceptable quality of life is judged from your values, what that involves. Generally, it's to be free of undue pain, like limited suffering, but a capacity for enjoyment. So you may not wish to be on mechanical life support if you're in a persistent vegetative state with no hope of recovery. But there's lots of gradations in between that makes it hard to make a decision. So it's best to have family and friends that know your values with previous discussions. And you want to choose someone that you trust to respect your preferences. So they'll do what you wanted them to do rather than what they want to happen to you. It's best to inform your family doctor if you have one and to put it in writing. And it should be revisited year by year so that it's up to date as well, because circumstances and preferences might change. So there's a link in our handout, my key points handout, how to have your best hospital stay. So on the bottom of the second column is a link to My Voice. So this is actually a really good advanced care planning guide. So it's a good starting point before you have your discussion with your family doctor to can download this. I think there might be some print copies somewhere that you can request, but it's downloadable as well, and it could be printed out. And it kind of takes you through the steps on what different procedures are available. How do you make decisions? Who you should talk to? So that's a really good do-it-yourself guide that you would bring to your family doctor if you have questions, and we're happy to do that. That's kind of our role in making your wishes known, because our goal is to help you meet your goals and to maintain your health and give our best advice and support. There's another document that everyone in a long-term care facility and every patient that's admitted to the hospital, they usually want you to, or the attending physician, to complete this the MOST form, which stands for Medical Orders for Scope of Treatment. So it kind of gives these guidelines to clarify whether or not you should have cardiopulmonary resuscitation if your heart stops or if you stop breathing, if they would call a code blue if you were discovered to be not breathing. So people first have to decide, do I want CPR or should I have DNA CPR, which means do not attempt CPR. So not having CPR doesn't mean that you won't get the rest of your medical care. For example, we would still treat pneumonias, infections, fractures, anything that comes up, depending on your level of care that you choose. So it's always best to kind of go over this in advance of going into the hospital so that you can anticipate the kind of care that you would want to have. So there's also a link to this on the form as well, but you can also Google MOST, M-O-S-T, Fraser Health, and they'll show you some examples of the MOST form. There's also a great handout you should look for. Uh, it looks like this. This one is from Fraser Health. So it's medical order scope of treatment. It's actually just a handy way to kind of guide you through what the different stages of level of care is. So I can walk you through this briefly. I think I have a Zoom to show you. Okay, so this section is, so you decide CPR or no CPR, and there's different levels. So if you are on the highest level of intervention, that means you don't mind going to the cardiac care unit or acute care unit, that's like CCU or ICU, intensive care unit, I mean. So CPR C2 means you would want CPR. If you were not able to breathe on your own, then we could intubate you, a tube down your throat. You would be sedated or not conscious. If you needed care at another site, um, for example, switch to another hospital with a higher interventions, then you agree with that. And of course, we treat reversible conditions, and we of course treat symptoms and comfort management as well. So that's the full level of care. So young person, car accident, brain injury, heart attack, unable to communicate their own or breathe on their own, they would go for the whole meal deal. However, if I was really elderly and knowing that really elderly with multiple chronic conditions, CPR is not likely to be helpful, or I'm not likely to survive because the condition causing the cardiac arrest or the respiratory arrest is not a reversible condition, for example, then I might elect, but I'd still want to be in the CCU or ICU, for example, after a heart attack or a stroke, then the level would be do not attempt CPR, so no CPR, but still C2 otherwise. And that could include intubation, tube down my throat, and all the other things, the critical care, site transfer, treating reversible conditions, and comfort care. So C1 is just one step down. So that's still intensive care unit or cardiac care unit, ICU or CCU, but I don't want the intubation. Because I know that once the tube goes down, I might be dependent on a machine. If I have a condition that's not likely reversible and where it's unlikely that I'd be able to come off the life support, then I might choose not to have the intubation and do not resuscitate level C1. You still get otherwise full medical care. A step down from that, if you do not want to be in the intensive care unit or the cardiac care unit, the level would be do not resuscitate, M3. And then at level M3, you can be transferred to a different site or higher level of care if it's required to treat your medical conditions. And of course, we treat reversible conditions and provide comfort like pain control. Level M2 means you're not going to have CPR or intubation or critical care. And usually you would stay in the same place, the same level of care. So if you're in a long-term care facility, you'd stay there. If you're at home, then you'd stay there, unless you need that for control of symptoms. So we might choose something like this for chronic end-stage disease, where we're still going to treat that condition as much as possible and provide comfort care. And then that level down at the bottom is do not resuscitate, level M1. That means we provide comfort care only. So this is an example of palliative care. So we treat symptoms like pain or agitation, but if someone develops a pneumonia or an infection that we otherwise would treat, then they're not treated. So that's an individual decision. And usually that would be if you have a progressive terminal condition, like metastatic cancer that's not curable. And if you were to get pneumonia, we wouldn't want to treat it because it would just extend your life and not the quality of life that you would have chosen. So these are the different levels of care. And this does require kind of a conversation with a healthcare provider. Decision number one is deciding on CPR. And then decision number two is the level of the healthcare that you would choose. Again, M1, think of it as comfort care and symptom control. M2, treating reversible conditions. M3, level up, medical treatment, but no ICU or CCU. C1 is critical care, ICU or CCU, but no intubation, no breathing tube or respirator. And C2 is the full meal deal, critical care, including intubation. And as I mentioned in the last slide, M1 and M2, comfort care, symptom control, even though we intend to stay where you're living, if it's required for symptom control or to treat that reversible condition, you could be transferred to a hospital or a higher level. Okay, and the other important thing is documenting. So a physician has to complete this and sign it, but it's usually with discussion with you if you're a capable adult, or the relevant conversation with your substitute decision maker, which is usually your next of kin, your spouse, or if you don't have any, then a close friend that has had the conversation with you. So it's carefully documented and updated as conditions change. And again, this doesn't have to wait until you're in the hospital. It's something you can decide ahead of time with your family doctor, because we have these forms that we can print out from the office. So that seems very complicated, but it's really important to plan in advance. So this is kind of tongue-in-cheek, but there's other simpler examples of advanced directives. For example, if you're going for toe or foot amputation or knee surgery, you might want to leave some notes so they don't operate on the wrong leg. So a Sharpie is kind of handy. And if you're going for a hernia surgery, but you want to make sure that they don't do an orchidectomy or a vasectomy by accident, then I would write these notes on myself as well. And what to pack. So what do you pack for a trip when you don't know what the weather's like? Well, it can get cold in the hospital, so bring a sweater and a blanket, but not your favorite blanket because it could go missing as well when you're sleeping. I recommend some earplugs just in case a neighbor is snoring very loudly, or there's lots of noises or codes being called that are waking you up at nighttime. It is really hard to sleep in the hospital because there's always some activity going on. Bring some reading material to help you sleep at night and while away the hours while you're waiting for the next procedure or test or to get better. Bring some music. With headphones might be handy to have. Maybe some word puzzles. An eye vest might be good because lights are always going on and off. And you might want to take a rest during the daytime too. And of course, toothbrush and toothpaste. And warm socks and non-slip slippers are good because hospital floors are very slippery and falls are a major source of complications when any of us are in the hospital, especially if we're taking medications that can throw us off balance or sedate us, or we're suffering from a condition that puts us off balance as well or confuses us. So key things to pack along. It's easy to get confused in the hospital, especially if you don't have a window room, so you can't tell the time of day. You don't have to go to work. You might not have a TV, so it's hard to figure out what day of the week is. And of course, doctors are always coming in and then checking our mental status. And the first thing they ask is, what's the date? What's the day of the week? So that's one of our screening tests for dementia or cognitive impairment. So it's best to keep up to date and oriented in the hospital. Really important for communication to always have a big pad of paper, some pens. If you need it for communication, glasses, reading glasses. If you needed a hearing aid, or you want to be able to speak better and you have false teeth, then bring along your teeth. You should not bring really expensive things like your fanciest, latest iPhone 15 or really expensive jewelry. Jewelry, including rings and watches, are removed if you're going for some medical procedures like MRIs. They're often removed when you're having surgery. So it's really important if you have really valued possessions not to leave them in the hospital. Wallets versus credit cards, they are prone to go disappearing, not due to hospital staff, but sometimes visitors to other patients on the ward, less likely other patients, but don't bring your designer clothes or your most prized possessions to the hospital. Get a loved one to take care of that. And bring all the stuff you need when you're happily discharged from the hospital. And don't even bother with perfume or cologne or makeup, even if your nurse or doctor is really good looking, because the I'm pretty sure no one meets their future partner, romantic partner at the hospital. You're kind of looking at your worst, so don't bother to cover it up with makeup. And perfume and cologne can really bother other patients that have respiratory conditions or allergies. So I wanted to further follow up with 3 keys to a better stay. Number 1, how to stay in control. Number 2, know your healthcare team. 3 is set up a channel of communication. Unless at your hospital, and many of ours do, they have a communication board or system that really keeps the patients informed. So that's some of the progressive hospital care that we provide in many of our lower mainland hospitals. So some keys to stay in control, know your team, and to communicate. So number 1, because it's such a depersonalizing experience, it's often to feel kind of powerless when you're in the hospital. So 4 things you need to know about every test, procedure, and treatment. Please don't hesitate to ask. I don't think they'll think you're a difficult patient. You can quote me and say that I recommended it as a doctor that's spent lots of time in the hospital. So you really need to know this for any test, procedure, or treatment, including medication. Even in your family doctor's office, even at a walk-in clinic or emergency, you need to know, number 1, if it's not clear, the purpose or reason for this drug, for this blood test, for this radiologic procedure, or for this surgery. So what is the reason? What are we trying to treat or cure or get rid of? What are the common side effects or risk of this procedure? For example, a colonoscopy, which is a procedure to check the large colon with an endoscope, usually performed by a gastroenterologist or a general surgeon, each skilled in this procedure with some sedation. The goal is usually to check out the colon to look for any polyps or inflammation, any source of cancer, or a source for example, bleeding or bloody diarrhea. So that's the reason for it. Common side effects would be, of course, sedation. You have to take a prep that can supposed to give you lots of diarrhea to empty the colon of all the poop, so that they have the surgeon or the gastroenterologist has a good view. Very rarely a patient could have a perforation where we actually poke through the wall of the colon, and that can cause a serious infection. So not too common, but that's one of the serious side effects or risks. So you need to know about that so you know what signs to watch out for. And you also need to know the alternatives. If I don't have this procedure done, what are the risks? And the risk could be that we don't identify the cause for the bleeding. It could be a tumor or cancer, but there might be other ways that we can screen for that with particular types of scans. So we need to have that alternative and let you know the downsides and upsides of those alternatives too. So the purpose and reason for the procedure or test or drug, common side effects, and then really serious side effects, even if they're rare, and alternatives to this treatment. Your healthcare provider will probably give their recommendation, what they would recommend, and they might be able to quote the statistics of the likelihood of common or serious side effects. And we need to explain it in a language that you understand. So if we're using Greek or Latin words that don't have meaning to you, don't hesitate to ask us to write it down, or better to print it for you, or to give you some reading material or connect you with some resources if you need more information. So we need to really answer all your questions before we can say that we've really achieved informed consent from the individual. Number 2, know your team. So ask each person's name if they don't introduce them as your nurse for this shift, or your hospitalist for your hospital stay, or I'm your internist or your cardiologist or general surgeon or ear, surgeon or orthopedic surgeon. So we should introduce ourselves and tell you what our role is. But if we don't, and you can't read our name tag, please ask us. Also, you need to know who is your attending physician. So that's the MRP, most responsible physician. As I mentioned, often is on your name tag. Their name is also put on that binder, kind of as a subtitle. So when they're doing rounds, and they know what to round on. Often, if you're under the hospitalist, they work in teams. So and they they might see you for a number of days and then turn over and you'll see another hospitalist, or one will be working days and one will be working nights. But we should always know if you have any questions about your care, about a medication, about a procedure, or the results of a test or investigation, that's the person you're supposed to ask. Often the nurses are not permitted to give you that information because it requires interpretation and relevance so that someone can answer the question. So often it's the physician, the most responsible physician, that should be explaining it to you in the language that you understand. Number 3, communication. So you know who to talk to, you know who your team is, and the key is communication. So often when you're waiting around for the physician to come, and some physicians I knew in the past were kind of rounding earlier in the morning because they could do it so fast because all the patients are sleeping and they can't answer any questions. And then some physicians rounded late at night after the patients went to bed. So you kind of need to know when that physician usually comes around. So the nurses usually be able to tell you. But if you kind of miss out on them, it's really important to prepare your questions or list of questions ahead of time because you often have all day and all night to think about it. So, and find out when that physician is attending. So write down your questions for them. And that pad of paper is really useful for that. For leaving a note for the physician, or having the nurse leave a note on the chart. So when the physician is doing his or her rounds, they can address those questions. Or even having a little note, please wake me up if I'm asleep because I really, really want to talk to my attending physician. Set up a channel of communication with your attending. You want to know what your working diagnosis is because sometimes we end up in the hospital from a fall with confusion, and we have multiple different diagnoses that we're trying to work through. A lot of people that end up in hospital, particularly the elderly, might have a number of different things going on, like reduced kidney function, also congestive heart failure, or diabetes, or electrolyte, sodium, potassium abnormalities. There's a number of different diagnoses and conditions that we're treating. So you also want to know what tests they're planning, what procedures they're planning. You want to have that discussion before they're done so you know what they're for and what the risks are. You also want to know the results of those tests. And you really can only get that information from your attending physician. And it's useful to know what the plan is. As a healthcare team, we always want to know what the plan is. So when is the patient expected to be able to be discharged back at home, hopefully? So these things could be set up. And a lot of hospitals actually have that on a whiteboard. But if they don't have a large pad of paper and lots of pens by your bedside, again, not your prized possession fountain pen, but disposable pens that you don't mind going missing or falling off the bed. So Burnaby Hospital had this great board so you can understand your stay. So that includes the date, who your nurse is for the day, the name you prefer to be called by, special limitations or specific instructions, and knowing who who your physician is, and what is the goal for the plan today, and when you're going home. So kind of the whole plan, it's a really useful thing to kind of go through. And then on that board, the different hospital staff, like SLP, speech language therapist, might write in one colored pen, the social worker with the green pen, occupational therapist, physiotherapist with blue or purple pens, and the nurse with the black pen. So they can often add their messages, writing down messages that you want to communicate with family as well. So the last bit about communication is make sure your family doctor, if you have one, knows that you're in the hospital. Many times if it's a Lower Mainland Hospital and Lower Mainland Family Doctor, they usually will get a notification of your admission. They usually will have some of the lab results, but not all of them. Some of the key investigations like X-rays, CTs, MRIs, usually those also go to your family doctor. The key is when you're admitted that they know who your family doctor is. So even though it's not likely your family doctor still goes to the hospital, his office can provide useful medical information that's important for your care. And often if we discuss advanced medical directives and you're not able to communicate at that time, we can share that with the hospital as well. And the key is really patient-centered care. So this is kind of a display in Burnaby Hospital from a number of years ago, just talking about, I believe they're kind of written by patients and how they appreciated the personal care that they received from all their healthcare providers in the hospital. For example, this is actually written by a staff member that they love recognizing each patient's strengths and incorporating them into the personal care plan. So my 3 wishes for you are for you to be happy, to be healthy, to be prepared. And I think together, we're all responsible for the health of our community. And a lot of this information was really practical, but you may not need it right away. So the key points handout is really a useful thing for you to keep. If you haven't had the discussions about advanced medical care, about most document the medical scope of care, or that My Voice Advanced Medical Directive, you should key and look at those resources, maybe start that discussion with family, talk to your family doctor to set up an appointment to discuss it. It requires more than just a regular visit, and it's not something you should kind of tack on with looking at a skin rash or mole or treating your knee pain or back pain at the same time, but a dedicated visit so you can have a discussion of your overall health. If you don't have a one-page medical summary, your doctor will have all that information. If your medical information is kind of scattered all over the place, it really would be good. That's really important to have. I think if every patient had that and brought it with them when they went to a walk-in clinic or urgent care clinic or the emergency, it would make things so much better for them so they don't have to memorize everything, or if you're not able to remember things or you're incapacitated, at least all that information is there at your fingertips, and it will kind of guide the care so you're not given something that's inappropriate for you. So I left lots of time for questions. So I see there's a number of comments in the chat. So hopefully that's lots of questions that Leona can read out to me so we can share it together.
Most, that's pretty much all me, but we do have some really good questions here, Dr. Wong. The first one is, in case a person has no relatives around, but he or she is hospitalized and the hospital really needs his or her bed while his or her, they're not feeling well, still well, how long can the hospital can discharge a person out?
Well, you shouldn't be discharged if you still need to be in hospital. So is the question, there's no one to pick you up or take you home, or is it because you're still not well and not able to live independently without assistance?
Yeah, so the question, how the hospital can discharge a person out. So perhaps someone's had a personal experience where they felt maybe they were discharged early. I'm not too sure. If you want to just drop your name in the chat, whoever asked this question, perhaps you can I can let you speak and you can ask Dr. Wong directly. That would be Monica. Another question I have in the meantime, I wonder if it's possible for a substitute decision maker to ask for having an intubator off if the patient's health status is not getting better and incapable of making their health decision.
Yeah, so that would be left to the substitute medical decision maker that you have chosen. So you would trust them with your values. For example, we can't anticipate every different scenario. Even after watching lots of Grey's Anatomy, you can't anticipate every potential complication. So, and then everyone's values is different. So some people might look on the outside that a patient with mild, moderate dementia, so they don't remember what they had for breakfast yesterday, but they do remember and they do enjoy the company of their kids and their grandkids and their neighbors and their friends. So some people from the outside will think, well, some with moderate or even severe dementia, then that's poor quality of life. Why would they want to, treat treatable conditions, or why would they want to be resuscitated? But when you know that person's value and you know that in spite of that chronic condition, they're enjoying a good quality of life, that they are not suffering a great deal, that they're enjoying the company with others, that they have really positive experiences and their life is worth living. So those are indications that if it's a treatable condition, they'd want to have it treated. And maybe even if there's a good chance that they will respond to intubation, that they, depending on the condition, that might be appropriate. But then that person, any person can't anticipate all conditions. So if someone's in a terrible accident and massive brain damage, and it's really clear that they're never going to regain consciousness, and they are on life support, it might be appropriate, it probably is appropriate for the substitute decision maker to make that decision, knowing this individual and their values and whether or not they would want to be kept alive by just a machine with no chance of recovery of their awareness, being able to recognize people, to do things that they normally would enjoy, where there can be a lot of suffering from physical pain, but not be able to express themselves. Then that substitute decision maker that knows your values, the patient's values, from the patient's perspective, can make that decision.
Right. That's great. Thank you. Last question. In the booklet, My Voice, there are two forms. One is the advance directive and the other one is an RA, representative agreement form. Which one do they need to prepare?
Probably both of them. So that if you want to indicate who your substitute decision maker, that's really important. Because they are always the backup. So the advance directive indicates what you do and don't want to have. But as I mentioned, sometimes medical scenarios and prognosis is a little bit more confusing. And you do really want someone that knows you really well and knows your values to be able to play your role and do what you would want to wish for yourself at that time. I think both are really important. Again, bring it to your family doctor so that they can review it to you, because there's always questions. And sometimes when I go through these documents with patients, they start seeing things in a different way. They might decide things a little bit differently because of misunderstandings or lack of clarity with some of the medical words.
Right. Yeah, that's really important. Really important. So that's it for our questions so far. I just want to let everybody know that the website is up to date. Those documents that Dr. Wong referred to are all there. So the presentation, tonight's presentation is there. The key points document for the hospital stay is there, and near the bottom are links through to these resources that he's referred to, and the how to be, I can't remember what it's called, but it's your everyday meeting with your doctor form. What was that called again, Dr. Wong? Anyways, that one's there as well.
It's the doctor-patient relationship. Actually, the
Yes, that
patient-doctor
one. Yes,
relationship. Yeah, I always put
exactly.
patient first. So patient-doctor relationship. So kind of the key things we're communicating with healthcare providers, and kind of have to watch out because we easily fall into med speak using kind of lingo or terminology that not everyone understands. So please stop us if we fall into our native tongue, Meta, Greek, and Latin. Those words are important for you to know, so we should kind of write and print them out. So I use a pad and paper and sticky notes all the time in the office so I can print things out for patients so they know what the medical name is. And I try to explain it in simple terms that lay people can understand. But it's really important to have that medical term for a procedure or a diagnosis so you can look up the right information for it and ask any questions that you have.
Right. Great. Actually, we got a couple more questions. Where can we get the scope form from?
You can Google MOST. It's medical order scope of treatment. So it's actually online. There's the healthcare providers form. So you wouldn't really, it has to be filled out by a healthcare provider. Usually it's physician or nurse practitioner, but it's with discussion with you. And then normally when I complete it with patients, we keep a copy in the computer record for that patient. We also give them a copy. A lot of people will keep it on their fridge. So there's a lot of older adults with chronic end-stage conditions will actually keep that in a green envelope on their fridge so that There's also things people can complete so that if they wouldn't want to be resuscitated at home, like if, for example, someone with palliative care, they have this green envelope or green sleeve on the fridge so that when they pass away at home, which is what they planned, in comfort surrounded by their loved ones, if ambulance is called at that time by a family member, usually it's not required, but if someone panics, calls the ambulance, it's clear that they don't want to be resuscitated, that they're not going to attempt CPR in front of the family because we know it's not going to be successful. So that do not attempt CPR form or expected death at home form, which is another document your doctor can complete. That's kept on the fridge so that that can be shown to the ambulance. They know that's the place that we keep things. These
That's a really good
important
idea.
documents. Yeah, and then if you do go to the hospital for some reason, it's good to have recent most completed or an advanced directive completed so that that could be shared with the hospital staff. And make sure your loved ones know as well, the people that look after you.
So I did put the link, so from the information sheet that you created, I did the most form, the Fraser Health version. So I have shared the link to that in the chat.
Thanks, Leona.
No problem. New question. Can a substitute decision maker override what's stated in advance directive?
They would have to show a clear reason, and it has to be based on the patient's individual values, and it has to be what that patient would have wanted. One thing that they might override is some people might decide they want to be resuscitated, but actually the healthcare providers, if they feel that resuscitation, there's no chance it's going to help, they're not going to actually do CPR and defibrillation. Like if someone was if someone had a cardiac arrest during the night, and obviously it happened during the night, and like a long period of time has passed, because we know within 5 minutes, if you're not getting blood and oxygen to the brain, then there's serious brain damage starting, and then there'd be no chance of success with resuscitation with an unwitnessed arrest.
Right. Okay, well, that's that. You covered it. All of our questions have been answered, and I just want to let folks also know that when we end this session, there'll be it'll be a 9-question survey that's going to pop up. If you wouldn't mind taking a couple minutes to answer those questions for us, that would be great. Dr. Wong and I review those after every talk, and definitely take into consideration your feedback and your thoughts, and so it is really helpful to us. Aruna said, thank you very much. Thank you, Aruna. I'm glad you were able to join us. Anything else? Don't forget to register for our February 29th talk, which sounds so strange to say, but it's February 29th is our next one. It'll be a Thursday night. I will be sending you guys a reminder if you're interested. If you're not already on our mailing list, the survey, the end of session survey, will ask for your email. If you're interested in receiving notifications, then you'll get a message from me to register.
Yeah, don't miss the February 29th talk. We only do it every 4 years.
Yep. And then we'll be coming together in May for a walk with your doc. So I'm just waiting on the final dates for that. Can't believe it's here already.
Yeah, I love that community walk because it's a chance to see you in person and to really connect. It's really hard to do things virtually where I don't get to see you and don't get to meet with you after the talks, but that's an opportunity that we could talk in person. You can ask me any question, as long as it's not necessarily medical advice.
Yeah, exactly.
And of course, all our family docs that are active in the community are often there. So usually we have at least a dozen of my family doctor colleagues there. So it'll be great fun and just really promoting being outside, being together, and physical activity.
Yeah, it's held mid-May, and we've started doing it on a Saturday, so to incorporate more folks, and that's another one of the things that are in my purview to plan. So if you're on our mailing list, you'll get a little invitation from me directly to sign up for Walk with Your Doc. So stay tuned for that. The weather will be nicer, I'm assuming.
Yeah, it's better because we tried to do it in the fall, or the Doctors BC tried to do it in the fall, and it was quite cold.
And yeah, it got dark. It did get dark. So anyways, well, that's everything for me. Hopefully the links that I shared in the chat were helpful for folks. And yeah, I think that's it. I've got it covered. My stuff covered. How about you?
I think we're all good, and I wish all of you a really healthy 2024 without having to go to the hospital. But if by chance you or a loved one have to go to the hospital, you're going to be prepared and to be as proactive and to ask those key questions. And if people are thinking you're being difficult, you can just quote me.
Yeah, there you go.
Okay,
Uh,
everyone stay safe and warm. Be really careful overnight and tomorrow if it's icy and slippery, and stay home if you can.
well, yeah, that would be nice. Yeah, just stay home, be cozy.
Okay, and thank you, Leona, for all the behind the scenes work.
Thank you to you too. All right, it's my pleasure. You guys have a great night. Take care.
Okay, take care. Good night.
Bye-bye.